presentation.
Okay, there we go.
Before we start the slideshow, I just kind of like to ask folks, when you're assessing an individual and you're assessing for PTSD, what question do you usually start with? What's the screening question that you use? Do you have nightmares? Okay. Nightmares is only one particular piece of PTSD, but think about the fact that there is a criteria that asking about the nightmares you're missing. So you have to have exposure to the trauma before you can have the other pieces. So I'm encouraging you to consider looking at Carlot and thinking about what the screening question is so that you can begin from that particular point. So Simone, if you would, I guess you're going to change the slides.
Sure thing.
Okay, so in looking at PTSD, which is what we're going to start with tonight, the DSM-5 criteria for PTSD, it had been moved from being an anxiety disorder to being into its own chapter. No longer is it considered as an anxiety disorder, but you'll see many people who may still consider it as they're doing screening for anxiety disorders because that's the way that they were trained. And that since 2013, people who've been trained since then don't consider anything about it. So with the process of beginning this, there is one thing that you absolutely have to have, and that is criteria A, which is exposure to an actual or threatened hard thing that has the potential of causing death, that is traumatic. They could have been near death with their injury or some form of sexual violence. So a good screening question in this particular case would be to ask, what is the worst thing that's ever happened to you? Which allows the individual to begin to discuss this particular event, or for you to get a flavor for whether or not they've ever been exposed to anything. This would be a good time to ask your question about have you ever served, as a gentle way to enter into this, particularly if you don't know whether the individual you're dealing with has had military experience or not. So have you ever served is a great way to begin a segue into this section, particularly if you don't know whether the individual you're dealing with has had active duty time or not. Of course, with children, looking for PTSD is going to be significantly different, and the way that they present is going to be different. So we're going to talk about adults initially to kind of set the stage for that, but keep in mind that play and how the child interprets the event is going to be where you're going to look for assessing a child and their exposure to trauma. So what is required in terms of the intrusive symptoms is that you have to have one from that particular category. So what would you consider as an intrusive symptom when you're looking for this?
Side note, yeah, Jean, this is what the DSM-4 called the re-experiencing cluster.
Thank you very much. So we got flashbacks, we got nightmares. Okay, so you have to have one of these. Sometimes this doesn't occur in everybody, so when you're asking about have you got nightmares as your opening question, you may miss some of the other particular pieces. What is the general rule in terms of period of time in which this would occur in? What's your rule of thumb that you're looking for there? what's going to be your differential between an acute stress disorder and PTSD? More than a month is actually what the correct answer is on that. So that acute stress disorder is immediately following the stressor up to about a month. And so if they continue to have the symptomology more than a month, then the diagnosis would enter into the PTSD range. With post-traumatic stress disorder, it is not important when the symptoms began or how long ago that the trauma occurred, because many times people may use coping techniques to deal with the trauma initially, and that later in life, when they're exposed to additional stressors, their PTSD symptomology may come forward for the first time. They may utilize other techniques to quell down the symptoms, including the use of alcohol or drugs. Some folks who have had exposure to a threatened death situation may develop an underlying depression. So as you're thinking about how is this manifesting itself, asking again, what event may have happened to you that was the worst thing that you'd ever experienced? So that is just kind of helpful to do that. So the alterations in their cognition and mood are generally negative, in which irritability, insomnia, depressed mood. And what are some of the other presentations that you would anticipate having in the alterations in negative cognition and mood? What would be another complaint that the individual would have? Decrease in concentration, irritability, insomnia. Excellent. Okay, and there is a few other subtleties more than that. For some individuals, yes, they have hypervigilance, but they may not necessarily have a perception of the future. That when you talk with them about what's going to happen to them in a few years, generally an absence of goal-directed behavior may be present, and so they may not see themselves as having a really hard and strong future. So there is a general, as somebody said, a foggy brain and avoidance of crowds and triggers. So we're still dealing with cognition. So avoidance is about cluster C, that they would avoid crowds and triggers and places. So cognitively, you're looking for changes in mood, being irritability, having difficulty concentrating, and essentially a numbing sensation in which they don't feel like they can experience love or closeness towards other people. So when you're thinking about numbing, I don't feel anything. My kids and my wife love me, but I don't feel anything for them. So next slide, please, Simone. So this goes back over the particular core features, and we're reviewing it just to kind of hammer the information home. That exposure to an actual or threatened death, injury, or violence, it is required that the individual have experienced it or witnessed it, or learned it occurred to a close family member or friends, and repeated exposure to the details of the trauma, like first responders. So as nurse practitioners, you may have exposure to trauma through your patients telling you the stories of it, but they are particularly sensitive of the fact that they don't want to share, because there may be an underlying fear that by telling you it will hurt you. So people are generally going to test you before they share their story with them. One of the things about this particular criteria is that if the individual saw it on television, like a person who watched the planes fly into the World Trade Center years ago on television and watched it over and over again, couldn't be couldn't qualify for PTSD because seeing it on television was excluded from this particular category. Although I'm sure that if you were to ask people what was the worst thing that they ever saw or experienced, they may name the planes flying into the World Trade Center as what they felt was the worst thing they ever experienced. But for PTSD, that will not qualify. So we've got intrusive symptoms, and it's helpful to think about them in terms of intrusive symptoms and the avoidance symptoms to remember them in that particular way.
I don't mean to interrupt. I was going to say a couple things about B and C, if that's okay.
Certainly.
Kind of PTSD is generally as a disorder, is kind of a result of a physiological process that's supposed to be helpful. That if you experience something life-threatening, it's probably good for you to remember that and cues associated with it so that you could avoid it in the future. And that's really what acute trauma, acute stress is supposed to do. It gets your attention. A little bit of stress gets your attention, kind of makes you awake and alert. And that's what happens with you get in a car accident or a car swerves at you and you're going to kind of, just get out the way really quick. And the purpose of that, of our response, is to become very alert and mobilized to get out of that situation. Your heart rate goes up, kind of your blood sugar goes up, skeletal muscle blood flow increases so that you can run away from the lion, for example. But the cortisol that gets released has another function, the glucocorticoids, to help release glucose to be more available for fuel. But those hormones also have their other job is to act on receptors on your hippocampus. You think PTSD, you think hippocampal volume is decreased. That cortisol, when it goes up, helps with memory consolidation. Because it, after an event, a lion sneaks up out of the bush and you got to run away. It would be good if you could sort of get a real clear picture of all the details leading up to that, so you could avoid it in the future. So that's a survival promoting mechanism that cortisol serves after an event like that. But the problem is when it is stored so thoroughly that really subtle things can cue the trauma response. Little subtle things get, this is what happened last time when you got attacked. Okay, you got to get fully activated and run away. You got to launch a response to that. And that is the issue with these intrusion symptoms and these avoidance symptoms, because of course you're going to want to avoid anything that reminds you of the trauma. You don't want to watch TV, you don't want to talk about it, you don't want to go those places, because what the person is trying to avoid is being re-triggered, because it's the same way people avoid panic attacks, because they're miserable. So the avoidance of PTSD is avoiding the triggers. They're trying to prevent the re-experiencing. They want to avoid all of these cues and symbols and reminders. One other point about the intrusive symptoms is memories can be stored. There's the play-by-play component. There's kind of the what, who said what, who did what, but then there's also an emotional component that gets stored to memories. And when you're working with someone and they're talking about their sleep's really bad, they're really restless, they wake up screaming and fighting, but they don't remember the content of the dream, but they're tearing the bed apart and they're falling on the floor and they're kicking and punching whoever's in bed with them, but they don't remember, cognitively. That is the emotional, physical re-experiencing. So you can call that a nightmare. And actually, prazosin is really helpful for that, even though they don't remember it. So, and they may dream about, it may not be exactly, say the person, they were in a really bad car accident and they have these nightmares where they wake up sweating and they can't catch their breath and they're scared to death, which is typical when of a description of someone waking up from a nightmare, a trauma-related nightmare. It may not be the play-by-play, but the theme is similar. Like working with veterans who were in a lot of firefights overseas, they'll have a dream where they're not actually where they serve. They'll be, in their neighborhood or in a jungle or somewhere else, and they're under attack, and maybe their weapon won't fire, so it's not exactly what it was, but the theme is the same and the emotion is the same, and that is still a nightmare. Just some other things to consider when you're interviewing for that. And that's all.
So this is where I pick back up again where we talk about the numbing. So with the cognition and mood, the numbing piece, that they may have exaggerated negative beliefs, that they were at fault for things, that they are less than because of the experience that they had. Sometimes survivor guilt may enter in here. So the negative emotional sense, why did I live and my friends die? Which is something to consider as you're listening to people talk about this, about the feelings that they have, the wondering and not forgiving themselves for what they may have experienced. And as I mentioned before, they may have an inability to experience positive emotions. So people around them may be happy and joyous, but they seem to be unable to attach to those. So some common emotional senses that people have is depression, you would anticipate, but frequent irritability and anger and a relative intolerance for sensations, which would include strong scents that are common to what they may have experienced at the time that they were exposed to whatever their trauma was. Noises may be intolerable. They are probably not going to respond real well to high, intense, large areas, such as going into a movie theater that's pretty packed. So avoiding opportunities to be in crowds of people would be one thing to also look for. This reckless or self-destructive behavior is, you would kind of listen for, what have you done lately to feel like you're alive? And this might be riding a motorcycle at night, 90 miles an hour down 65. Because riding the motorcycle at that speed and feeling the adrenaline rush is the only thing that makes them feel like they're alive. They may also experience a startle response, which would be an excessive amount of hypervigilance, that when a loud noise went off, say behind them, that they would turn around to see what was happening or what was coming toward them. And because of this constant ongoing hypervigilance, they may have difficulty focusing on events at hand and have difficulty staying focused on tasks. The decreased sleep is cardinal in the sense is that it may look like depression, but if you listen to what's going on, going to sleep is a loss of control, and that returning to sleep might be a re-exposure so that they may experience the nightmares again. So the decreased sleep, sometimes it's helpful to ask, are you afraid to go to sleep? Or is this something that you can't go to sleep? Or is this about the fact that you don't want to go to sleep because of what happens when you sleep? They may choose to sleep in another bed if they're married because they don't want to have their spouse in bed with them, because they may feel that they have no control of themselves when they're sleeping, and they may act out in their sleep. Next slide, please. So, additional criteria for PTSD that you're going to be listening for is that the individual had to have gone at least 1 month since their exposure to this terrible trauma, that there was no onset criteria, so they didn't have a prodromal period before this. They were your average human being on the street, and there's no, they're going to have clinically significant impairment. So it isn't like they can go to work and everything's hunky-dory and they have PTSD. This would be that they're significantly impaired by what's going on in their thinking process and how they're interpreting it. Now, they're not able to have another attributable disorder, substance use disorder, or medical issues. However, I would say that it is not unfrequently that folks who have PTSD may use substances to cope with the emotions that they experience, to cope with the anxiety that they have. So alcohol is a frequent GABA enhancing agent that they may choose to use, or they may choose to use other substances. Opioids in particular can be helpful if they're feeling like they are overstressed, because the opioids are going to relax them and numb out their brain. So thinking about what other things they're doing, it could be helpful at this point to say, so what have you been doing to try to cope with this? Because people might choose to tell you what they've been using to deal with this, particularly if they haven't shown up to be seen for months after the experience, because they may have tried to treat it themselves at home. So a specifier with this would be dissociative symptoms, in which that they dissociate from the experience and see themselves as if. Depersonalization is one piece of this, in which they don't feel like they are present, and derealization. And Simone, if you could help out with the definitions here, I'm not going to be useful in clarity on these particular two.
Yeah, depersonalization and that's real common with any kind of trauma exposure. Trauma seems to cause disconnect between kind of your awareness of yourself and who you remember yourself to be, and awareness of the outside and what's currently happening. So depersonalization is when you feel like you're not in your body, like you're sort of separate from yourself, maybe watching yourself do something. You might feel numb from head to toe. It's like you're not even in your own body anymore. And then derealization is more when the outside doesn't seem right anymore. Things don't seem familiar. You're having a hard time connecting past experience and sort of mapping the present onto that. So somewhere you've been a bunch of times might, like, have I been here before? Is that a memory or is that fake? I don't know. So that's, in either way, that's a sign of extreme stress, and your consciousness. I don't know. Did we talk about default mode network before? I don't remember.
Did we talk about what? You're breaking up.
Yeah, the default mode network.
I don't have any recall for that, but other people may.
Maybe not. But it's three main systems in our brain whose job is to keep track of, kind of our inner experience and then our outer experience. And trauma tends to disrupt the communication between those two systems. And often this dissociation happens. Folks will say, somebody came up behind me and startled me, and I turned around swinging, and that's the last thing I remember. And what that they're describing a dissociative episode that was triggered by that hyperarousal. Real common for extreme, folks with really severe PTSD to describe that.
Quite distressing for the individual too.
Mm-hmm. Hard to keep a job. When you talk
Yeah,
about clinically significant
yeah,
impairment, that's really the issue. Hard to keep friends, relationships, employment.
it compounds the feeling that they're crazy and they are not in control, which
And
is
it's gonna reduce support. It's gonna reduce
uh,
positive, healthy relationships. And folks with PTSD really they're in conservation mode, and they really kind of don't want people around them. But being in healthy relationships is really helpful for people. There's hormones that are released when people are in healthy interpersonal uh, relationships that can help try to correct some of this. You talk about sympathetic, parasympathetic. Your parasympathetic system is exhausted because it can't compete with the constant sympathetic activity.
uh-huh.
And relationships can actually correct that. And from a survival standpoint, you're just trying to push anybody away who might need something or cause you more difficulty.
I would remind folks that last summer, you all had an opportunity to read the von der Kolk's book about the body keeps the score. And I would refer you back to that as we go through this chapter in terms of the long-term effect of exposure to trauma. So acute stress disorder, really briefly, is where you would start from. Say somebody experienced a terrible trauma and they came to see you. Most of the time, however, even though this diagnosis is listed here, it's important that you know about it. It's highly unlikely that anyone is going to show up on your doorstep in a way that you're going to diagnose them with this particular episode.
Uh-huh.
Acute stress disorder is 30 days or less, and usually this is handled within family or within a different set of providers. They may choose to show up in the emergency room, but it's unlikely that they would show up in a psychiatric practice to be treated in the acute stress phase. So again, as similar with PTSD, they have to have exposure to the actual or threatened death, injury, or sexual violence. So again, here would be the question about what's the worst thing that ever happened to you, and then go from there to ask, when did this happen? So if it happened 2 weeks ago, then you would know this is an acute stress disorder, and the treatment options are going to be different than if you're dealing with post-traumatic stress disorder. So acute stress disorder, generally, even though it is the preceding thing to post-traumatic, it's important to keep in mind that you want to help the person utilize available resources to them. So you're going to have the same symptomology, 9 or more from any category that they have to experience in order to get this diagnosis. Next slide, please, Simone, unless you want to say more about this particular one. Go ahead.
No, I was saying that was about it. Like, the main distinction is that those dissociative symptoms seem to be more prominent in acute stress than it is in PTSD, which makes sense because the hormonal changes responsible for the symptoms of PTSD haven't necessarily had a chance to grab hold yet in that short amount of time.
Uh-huh.
But otherwise, like you said, it's the same criteria.
Yeah, but generally the treatment options for acute stress disorder is you really encourage people to utilize available resources, family members, whatever they normally do to handle stress. Most folks, when exposed to trauma, handle it eventually, and if they don't, and it lasts longer than the 30 days, then more than likely you would deal with them further. But again, it is highly unlikely that you're going to see anyone in this particular case. It used to be that they would do debriefing with individuals who've been exposed to stress, but they found that the debriefings were not actually very helpful for folks. So just helping people to utilize the resources that they have to help them to get sleep, to ensure that they do the basics, which is that they eat and they sleep and they are safe wherever they're at. So it's generally Maslow's hierarchy of needs with acute stress disorder, that and sleep being one of the biggest and most important with this one. So next slide, please. So risk factors, higher prevalence in women, personal nature of the trauma is also a risk factor, and the age at exposure. So generally, because younger people have less available resources, they're more vulnerable. Any individual who has had a history of trauma in their life is going to be more vulnerable because they already have had essentially changes in their brains. The repetitive nature of the stressor also can be a risk factor. So folks who are in combat situations are going to be repeatedly exposed to trauma, which increases their risk over time. So how deliberate the trauma was, whether it was torture, and also having pre-existing psychiatric illnesses increase the risk of folks developing PTSD or acute stress, and accumulative stress, which would be someone who, for example, if they were living in Houston, that the floods came, they lost their house, they had to move. Wherever they moved to was a bad neighborhood, that they were robbed. And so it would be a series of events that increased their risk. Protective factors, social support, a good social network, effective coping skills, which would include exercise, walking, getting a good night's sleep. So encouraging people to utilize available coping skills, whatever they are, and their strengths, is what you're going to be looking for as part of this particular function. Folks who have a poor premorbid function are more at risk than those who are not. So part of your interviewing process is you're talking to adults about their personal history, knowing whether they've had trauma in their childhood or not, will help clue you into what you might be looking at as an adult. So next slide, please. Simone, are you able to talk through this particular one?
Yeah, definitely. Trauma, of course, is not exclusive to people over 18. Something that the research consistently shows is that younger people, like Dr. Fogler was saying, even into infancy, who are exposed to significant stressors, tend to have a more, they're more likely to develop trauma-related disorders down the road, even when they see neglect, like infants who are not consistently held, not consistently attended to. Once they get to preschool, may have bigger emotional kind of tantrums if exposed to some sort of stressor, some surprise, some difficulty that other kids their age might get a little upset by, but not dysregulate. So, and that's something that is seen in mammals other than people, that neglect in infancy, which makes you realize, oh my gosh, this can have tremendous consequences at any age, not just, oh, you got bitten by a dog when you were 5, or you're in a car accident when you were 10. So if you have parents who are depressed, mothers who are depressed tend to be less emotionally responsive and available, and less nurturing. That starts kind of the cascade that could eventually present like PTSD. So young kids, again, the vocabulary is less advanced. Their ability to abstract, to kind of think big concepts, not going to happen with a 4 and 5-year-old. Their the medium that they have to express experiences is probably going to be in play, in drawings, in role play. The themes may be more violent. The themes of the play may be aggressive. They may be sexual. So that is, you wouldn't necessarily directly ask a child about those kinds of things. Your interactions with younger children, I mean, preschool for sure, and then early elementary school would be more revealed in play.
So, Simone,
Yeah.
I'm going to interrupt you at this point because some folks haven't got a lot of experience working with kids. So if you were interviewing a child that you suspected had an underlying trauma issue, how would you do that you incorporated play into the assessment process?
It would probably start with play. You would have a bunch of options out there for the child to pick from, and you would ask them, well, do you want to do something? What do you want to do? And they could draw if they wanted. You could have little figurines if they want to. You could do molding clay. Some folks do sand trays with little figurines, whatever you want to do. And if you can let the child lead the way, I would start by a way that I like to start a lot is, so show me who lives in your home. And we'll just kind of go through that, and who sleeps where, and when do y'all eat, and well, let's say this is your room, how's your room decorated, those kinds of things. And what happens when mommy or daddy gets mad? What happens when you do something really good? What do they do for you? And you're kind of listening for how open they are to talk about those things. Do they describe, discipline that seems more like abuse? Is because the child, younger kids, they don't really know that they're trying to hide anything. They're just going to kind of show you. And I'll say, well, how do they, when they fuss at you, what does that look like? What does that sound like? And, typically it's nothing, but that's a way to kind of see, is there something that makes you curious about overly harsh verbal abuse or overly harsh interactions at home, any kind of physical abuse. Do they hug you? Do y'all kiss before y'all go to bed? Do y'all hug when y'all get up in the morning? And you can have them take the little figurines and just show me how y'all hug, and show me how. And then you can move on to school and say, if you have another you can just use a table with some little people and say, oh, set up your classroom. And they'll put the little dolls on the table sitting in the classrooms, and show me your friends, and have them pick who the friends are. And, it really is like play. And do kids ever fight at your school? You can see if they're getting involved in any kind of, physical altercations at school. And, I'll ask them, how do you say hey to your friends? Show me how you say hey to your friends. Do you high five? Do you hug? Do you do those kinds of things? And other important adults in their life, how do they interact with them? Has anybody ever come in your house that made you feel uncomfortable? Do you always feel safe at home? Anybody come in your house that you don't like? And then ask them to kind of tell you about how that usually goes. So the kind of the main areas are going to be home with family, school, and then other adults who may come in the house. And you're not leading them, you're not assuming anything, you're just wanting them very, very
threatening.
You're not trying to seed anything, because kids are very susceptible, and you don't want to kind of prompt anything, which is the good thing about drawing. You just let them draw whatever, draw your house, draw who lives in your home, draw. And I'm obviously not. There are psychologists who are trained to interpret drawings. If the hands are behind the back, or if the person doesn't draw feet.
But for the purposes of our folks assessing kids, just using the drawing without interpreting it is helpful as a tool to begin the communication with the child.
Yeah, and just, it's just letting them use the language they're capable of, which may just be show me, kind of give me the play-by-play using these dolls, so it's not them. They're not really talking about themselves, which is automatically less threatening. Just act it out for me, and just show me your house, and show me how school is, and show me when you go to your friend's house, what do y'all do over there? You're not giving any ideas, you're not planting anything, but you're listening for relationships or behaviors that may be inappropriate, things that they shouldn't know. Discussion of anatomical language that they shouldn't know, or physical kind of sexual activity that they should not developmentally know about. And then, so that's kind of in the session, and you can ask family as well any change, because after a stressor, and not necessarily sexual, kids get, they get in car accidents, and they fall out of trees and hurt themselves, and animals die. Yeah, like the death of a pet or a car accident. You think about these poor kids in Florida. Granted, they were older. They weren't 5, but trauma sort of puts pause on things, because your challenge becomes surviving as an organism and not necessarily thriving as a sibling or a parent or a spouse or a citizen or a student or anything like that. And like Maslow's hierarchy, things go downhill. So you may have suddenly the child, and the parents may not know, why is my child is, my child's 6 and he just started wetting the bed, and he's not wanting to sleep in his own room, and he's coming in, he's getting really, really upset about things. All of a sudden it makes you wonder. Kind of functioning backs up when organisms are under any kind of stress. Your higher order functionings, those go offline to support more basic kind of functioning. So, and then, with adolescents, they may withdraw a bunch. They may get really, really angry, real irritable. You think trauma, cortisol's up, people are real irritable. They just have kind of more energy, and initially, at least, that they really know anything to do with. So just some signs to look for.
I think it was helpful to go over what you would do with the traumatic themes during play, because unless you've actually done it, it's difficult to imagine how you would do it. So thank you for walking through that.
And usually there's a good chance that the parents would be bringing the child in after they know something had happened. There was a car accident, or a parent died, and suddenly these changes are happening, and then you could go through that. So a lot of times play is used as much of a confirmation of what traumatic has already happened. Then, I am not a forensic mental health person whatsoever. So, but there are folks who are more trained to assess specifically for, for physical trauma or sexual trauma. But these are more so just some litmus tests to confirm something you suspect already.
So moving on to treatment options. It's helpful, like with any other diagnosis, to have a scale that you would be working with to essentially assess symptomology. And so there are several of them. Which one you choose doesn't matter. It might be that you decide that, depending on the individual that you're working with, that you may use one that related to military trauma, or not, depending on your answer of have you ever served, that you might choose one specifically related to military issues. So using a scale on a consistent level is important with this, as with any other diagnosis. When you're looking at medications, it's helpful to know what your targets are that you're choosing to treat, because SSRIs, which are medications that are pretty much first line for treatment of PTSD really require target symptomology in order for them to be helpful. So you aren't going to get complete remission unless you have a real clear idea that they have the targets that you're looking for, which would be the avoidance symptomology pretty much, which is going to help with the SSRIs are going to help with. So having that, it's not going to take care of everything. You might look at other medications to help with nightmares. For example, prazosin, which is an alpha-1 antagonist, has been shown to be helpful, and the dosage on that could be dependent on when the individual feels like it's making a difference. Some folks have difficulty tolerating the hypotensive effect of it, but for the most part, people can tolerate it if you raise the dosage slowly. So I've seen people on anywhere as much as 5 milligrams of the prazosin on up to 18 milligrams of prazosin, and the individual will let you know whether it's working or not, and if it hasn't started working, to increase the dose until you see that they're either getting too many side effects or they're getting some effect. So as far as therapies go, we're probably going to need to talk about therapies more when we get into therapy during the summertime, but EMDR is a therapy that's particularly helpful for PTSD. It is eye movement desensitization and reprocessing. It is a therapy that has got excellent efficacy and is evidence-based. Some of the other ones that are available are prolonged exposure therapy. And all of the therapy for PTSD is time-consuming, which means that if you're going to see people for therapy for post-traumatic stress, that you need more than a 15-minute med check in order to do that. So EMDR, prolonged exposure therapy, have been helpful, and they are evidence-based. Cognitive behavioral therapy is also helpful. In particular, very focused trauma, the VA has some excellent therapies. Somebody asked, is there a place that performs EMDR in Birmingham? I know of at least one therapist who uses EMDR, and I'm in the process of becoming trained in EMDR, certified in it, but it just really depends on the therapist's experience with this. So I don't know that there's a lot of places that perform it as much as therapists who utilize it as a technique. The therapy itself is definitely person-focused. As with anything else, the first thing that you have to do is kind of develop a trusting relationship with the individual. I will talk more about EMDR when we move to this section in the summer, but it is an opportunity for the brain, in essence, to process the memory and then let go of it and be able to move on. So it works really nicely, but it does take time, and it is not something that you can do really quickly. So next slide, please. So pharmacological considerations, we talked a little bit about FDA-approved medication, be sertraline and paroxetine, both of which can be helpful depending on the individual. They're fraught with side effects, and SSRIs may not necessarily bring a person completely in remission, but if it can help them to be less avoidant and start living more with other people, then it is about expectations to let the person guide you about how much the medicine's helping. However, I think one of the things I've noticed is that people have an extraordinary belief in how much help the medication's going to be, and I would just let the patient guide you for how helpful it is. Some other additional medication would be fluoxetine, mirtazapine and the venlafaxine, they're not FDA approved for this particular uh, diagnosis, but they can help a person sleep. They can essentially help deal with um, underlying anxiety issues that go along with it. Low and slow, but it may require higher doses. And again, with this particular diagnosis, sleep is highly important because people are not going to get better unless they're able to get some sleep. And with the substance use disorder, I would use the question about how are you handling this and what have you been doing to try to deal with this that's been so problematic for you, that people may say, well, uh, I drink 4 or 5 beers at night to help me sleep because I can't sleep unless I drink the beer. So it will help kind of assess what a person's doing with substance use disorder. You will see that a large percentage of folks with PTSD, and I think this is on the next slide, Simone.
Okay. Yeah.
There it is. A third of veterans seeking treatment for a substance use disorder also meet PTSD criteria. And 70% of veterans hospitalized for PTSD have a substance use disorder. So, like many other mental health illnesses, people do the best they can to try to treat the distressing symptoms, and substance use is rampant among this population because it's their attempt to try to manage the symptomology as best they can, utilizing whatever they have. So, the Department of Defense clinical guidelines indicate the need to treat both simultaneously, and depending on where you are in the United States, you may get cooperation with that concept or you may not. Some places refuse to treat folks who've got an underlying substance use disorder until they're sober, clean and sober, but in order to get a person there, they have to be able to tolerate the withdrawal of the very drug that helps to keep them somewhat stable, which is usually alcohol. So the PTSD has to be treated at the same time as the substance use disorder. Otherwise, you'll never get people to a spot where they can move forward. And that's some of the examples of why you have to treat them both at the same time. That one is not going to let go of what saves them from the exquisite pain of remembering unless they've got some way to deal with the exquisite pain. So high rates of comorbid depression and anxiety, which may be where your SSRI is going to be particularly beneficial. And again, and with the treatment that you might use as first line. If you have somebody that you can refer to, it's really great. And developing relationships with therapists is helpful because you may form a team in which the therapist is working with the patient to deal with their underlying PTSD, and you treat their medication with medication. So I've seen that team approach work really well. So it's important to know who you can refer to. Seeking safety is, I'm thinking that was an article that we had at one point in time. Do you remember that?
Yeah, seeking. We probably did have an article about it. That is a manualized. It's a manualized cognitive therapy protocol that is specific for folks with PTSD and substance use. By Lisa Najovitz is the author, and it's maybe like 12 modules. It's real helpful for like a group setting. And I think the VA, I want to say on their website, they recommend that or they endorse it as they do. Okay, Karen's saying, yeah, they do. It's neat. It has some good coping skills, but as far as a dual diagnosis approach, that's a manualized dual diagnosis.
Thank you.
Mm-hmm.
So essentially, because some folks are still got DSM-4 TR embedded in their head, the differences in the changes with DSM-5 is that it used to be that the individual had to have responded with fear, helplessness, or horror to the exposure of the trauma, and they removed that from there. So they separated the criteria of avoidance and numbing, so it was not one particular concept, but rather two, to be able to tease that out. And to specify with the dissociative symptoms, it used to be part of the avoidance and numbness. So some of the DSM-5 changes were to clarify a little better with what was going on with the individual. So
Yeah, and that symptom you talked about, the reckless or self-destructive behavior, that criterion is new to the DSM-5 that did not exist previously. So it's interesting how once exposed to trauma, there's almost a, this, some folks have a cellular, the apoptosis. I think I'm saying that right. When it recognizes an issue, it will sort of self-destruct. You kind of wonder, is it that process on a full organism scale?
Yeah, I think in particular with dealing with people with PTSD, when you begin to ask questions around that particular issue, that behaviors that the person may not even be aware of, other than the fact that that's the only time I feel like I'm alive, is when I experience that rush from riding real fast. How would you have a conversation about that if you weren't asking the questions? So have we got a few more slides with this, Simone?
Yeah, we were just going to try to give an example of a fella.
Just to kind of talk through treatment options so that if there were any questions about what would you do if, that we can kind of clarify that a little bit. So we've got this person who is 38-year-old, Caucasian male, who's a veteran of OIF, OEF, which are essentially operations into Iraq. Still serves in the Army National Guard, and the person has obtained the rank of E6, which is a sergeant. They have had 3 deployments to Iraq and Afghanistan, and the most recent one was 2009. So it's been a while since they've been back overseas, but it's helpful to know how long it's been since they've been there. They are married with 2 small children, employed as a supervisor at a factory, and their primary complaint coming in is that their temper has been getting them into trouble. So they report nightmares at least 5 nights a week and sleep 3 or 4 hours. They dislike crowds, will size people up, and they sit facing an exit as to essentially watch their back and find a way to escape should they need to. They prefer to be alone. They don't experience happiness or sadness. They have few friends that they trust outside the military and will not discuss details of certain missions and avoid the nightly news. Is there more to this particular one, Simone?
Nothing diagnostically.
Okay, so they drink 4 to 6 beers at night to unwind. They deny TOB, which is that tobacco use?
Yeah, any kind of tobacco.
Okay, or any other drugs. They take essentially lisinopril and HCTZ and a statin. Their BMI is 32, so they're overweight, probably not obese at this point, but they are considerably overweight. They've got frequent headaches, fatigue, poor concentration, and they deny major features of another mood disorder. So when asked, what are you feeling? They don't say they're sad or anxious, and there's no apparent thought disorder. I'm going to need your help here, Simone.
Yeah, so diagnostic impression, I think it's that this person would have PTSD, really classic, maybe too perfect, these 4 clusters of the re-experiencing the altered arousal pattern as far as not liking crowds. When I'm documenting notes for folks like this, I'll always say dislikes crowds or uncomfortable in crowds. A lot of times you'll see people write avoids crowds, but I think that is confusing as to the avoidance criteria, which is not avoiding crowds. That's not avoidance in the sense that this 4th one down here, they're avoiding reminders of the trauma. They're trying to avoid being triggered, like not watching the news, not wanting it. So, okay. So this is a pretty sterile, unrealistically perfect presentation of those symptoms. So, something important to ask anyone generally is, have you ever had a head injury, in particular someone who has been deployed 3 times in the service? You would want to ask them, so what did you do? What was your MOS when you were there? Because if they were infantry or a paratrooper or a tank commander, or I drove trucks and caravans, things that made them more likely to be exposed to an accident, a car accident, an IED, falling and hitting their head. You want to ask about head injury because of the implication that can have in treatment. Someone who is only sleeping 3 or 4 hours and it's not consistent, they're waking up a bunch, and they're pretty significantly overweight. What would you want to assess? What would you want to consider? Overweight, waking up a bunch in the night, tired all the time, frequent headaches, trouble concentrating. Yeah, that's pretty classic. Depression, certainly, but sleep apnea. When you're not breathing in the night and your body, whether you like it or not, is going to wake you up so that you'll take a breath, people will wake up, I can't breathe, and my heart's beating really fast, and I feel like I've been running, and I'm like panicky. It could be a nightmare. It could also be sleep apnea. So and sleep apnea is so highly correlated with our vets. It's unbelievable. So you would certainly want to consider down here. That's why we put sleep apnea. But headaches, fatigue, poor concentration is real commonly expressed by people with sleep apnea. So you want to be sure. And I've worked with a lot of vets. Well, let me not say a lot. I've worked with a significant number who, once they were on the appropriate kind of CPAP therapy, their nightmares improved. Because nightmares really are, norepinephrine is involved in reactivating those memory tracks of the event. And if you're kind of accidentally triggering norepinephrine from a sympathetic standpoint, because you got to wake up so you can breathe, well, you're kind of by default going to do anything else that norepinephrine activates, like nightmares. So really important. And people will not, if you need CPAP and you're not on it, you're never going to feel as good as you can unless you do you can do every medicine in the world and it's not going to help. So from a treatment standpoint, is that more beer than he should be drinking every night? Probably, yes. And that's probably not helping his weight, and that's probably not helping his sleep. It's also probably the only thing that helps him feel somewhat calm, like Dr. Fogger was talking about. Something to try to bring him down. Again, his parasympathetic system is torched, so he's going to have to bring in some sort of exogenous, meaning outside of his body, calming agents, like alcohol. So it would be great if maybe he could cut it down to just shoot for maybe 3 a night and see if that'll work. A risk reduction, just try to get him to reduce his use. But like Dr. Fogger said, that's the only thing keeping him sort of level. So to say just quit is unrealistic. But sleeping 3 to 4 hours, that's not very good. That's not much either. Let's see, he's on a couple of blood pressure medicines. He's on a statin. which interestingly enough, newer research is telling us that there seems to be a protective, and this is wild, but there seems to be a protective function served by cholesterol. That when cholesterol goes up, it seems to support parasympathetic system functioning. That your vagus nerve, which is your number one parasympathetic champion, seems to be benefited in its activity when cholesterol goes up. And with PTSD, your vagus nerve is exhausted. So, and anybody who works with vets, look back through their labs and just see what their cholesterol is. It'll be, easily in the 300s. So just cruise back through some labs and see how wild people's cholesterol is. Is that a kind of a feedback mechanism that their body's trying to maintain higher cholesterol because that seems to support vagus nerve strength? Maybe, yeah, Karen's saying, yeah. And what do all the primary care docs put all of the vets on? Statin, trying to drive that cholesterol down. And what we may actually be doing is impeding kind of the correction of the vagus nerve by trying to shoot cholesterol down. Granted, you don't want them to die of heart attacks either. So just interesting. Next time you work with somebody with PTSD, check their lipids. And of course, which makes sense when your glucose is elevated for a long, long time, your body's gonna have to store it some kind of way. So anyway, what medications might y'all recommend for Andy? We'll ask him to cut back his drinking a little bit. Send him for a sleep study. Check for sleep apnea. But medications, if you could give him only one medicine, forced choice, what would you recommend for him? He has PTSD, obviously. Prazosin? Sure. I think that would help. That would be one good option. And usually with most of the vets I worked with, I would be comfortable starting two medicines at the same time just because PTSD is a multifaceted syndrome. So yeah, it would be reasonable to start with an SSRI and something to help with sleep. Zoloft is great. Yeah, you can always justify starting with something that's FDA indicated. You can always justify that decision. And Zoloft and Paxil are two great places to start. Absolutely.
The only trouble with the Paxil is that this fellow's already overweight, so that might be a concern.
Exactly.
Paxil's an excellent drug for men. Generally, there is a difference in how people respond to things, but the other piece about that supports starting two drugs at the same time, going low and starting slow, is that sometimes you only get one opportunity, and that the individual took a risk and came in to talk to you, and if you don't help on that visit, they might not come back.
Definitely. Yeah.
So you want to talk a little bit about benzos?
Sure. Do you want to?
I was going to let you do that.
Oh, okay. Benzos are not a good idea. Benzos are not recommended. They are strongly discouraged for folks with PTSD. They are disinhibiting for people who are already capable of extreme dysregulation. You think to the point of physical aggression if they're triggered, if they're startled. So you don't want benzos for that reason, especially benzos with somebody who's drinking a 6-pack a night as well. The other thing is that so much of treatment for PTSD is designed to break the connection between the trigger and the re-traumatization. And benzos directly block new memory formation. You take enough benzo, you don't remember what you did. So you don't want to interrupt the desensitization to the trigger. So that's another reason why you put somebody on a benzo, they're never going to disconnect that trigger with They're never going to say you were bitten by a dog and you have PTSD because of that. If you never re-experience dogs with a good outcome, you're never going to unlearn that trauma response. So you don't want anything on board that's going to inhibit that unlearning, and that's another thing that benzos do. Plus, they don't play well with pain meds, and there's just a lot of reasons not to do it. And people will come in wanting that.
Yeah, I was going to add that because PTSD is a chronic condition, usually folks don't show up until they've exhausted all their resources, and benzodiazepines are considered for acute treatment, and so they don't match. But like Simone was about to say, is that a lot of times patients will show up and tell you what they want, which makes it a challenge to avoid using them, despite the fact that the patient would really like to have a prescription for them. You're not doing anybody any favor by going there.
Right.
If a person has traumatic brain injury, that would be another reason to avoid use of benzos, as well as to encourage the individual to avoid use of alcohol. Because with traumatic brain injury, the disinhibition that you would experience with alcohol can be really problematic.
Yeah, so for this guy, like you were saying, and what y'all are saying too, Karen was saying, Zoloft, is that from an FDA standpoint, considering this guy's overweight, and Paxil inhibits 2D6 strongly, so it's just going to potentially muddy up other medicine doses that they're on. Zoloft's a great start. The research shows that Prozac's a good one too. I've had a lot of luck. This guy has really pretty severe PTSD with that arousal. So he's getting kind of norepinephrine boosts when it's not helpful. And Zoloft, which is also indicated for panic, which is a norepinephrine related condition. Zoloft would be great for this guy. I would probably start at 25 for 3 days and go up to 50 and then see me back in a month, and we'll go from there. I've had a lot of luck with Lexapro as well for maybe not this severe of irritability, but Lexapro doesn't interact with things, really tends to reduce irritability, particularly in men. So if somebody, Zoloft makes them feel weird or zoned out, Lexapro, if you're concerned about side effects turning people off from medicines, that can be a good place to start. And if you would start something for sleep, I think Darby had mentioned prazosin. What dose would you start them at? What's a good, how long would you do 1 milligram? Or would you just stay at 1 milligram for a long time? A week is generous, Gene. Nothing wrong with a week for sure. Usually I'll say, if it's this guy's 38. He is on a blood pressure medicine, which is the kick. He's not on a beta blocker, which would be different. But you educate about orthostatic hypotension. Right, exactly. That's a blood pressure thing, mainly with orthostasis, because that's what alpha-1 does, is it keeps your blood from falling to your feet when you stand up. So you just give some education about orthostasis, particularly for men. You take it at night. If they have prostate issues where they're getting up in the night to pee, you want to really make sure they don't jump up and run to the bathroom. But you can do 1 milligram for 3 or 4 nights, and if they're tolerating it, they can go up to 2. That's no problem. And if they're tolerating that for 3 or 4 nights, and they're not noticing reduced intensity of the nightmares, because that's what people will say, that often the intensity decreases before the frequency decreases. They'll wake up, but they're not as startled. They don't remember what the dream was, and they can go back to sleep more readily. That's usually what you hear, but you want to get them to a level where even the frequency is reduced. But 1 milligram, 3-4 nights, no side effects. Bump it up to 2. Stay there 3 or 4 nights. Really, by 2 milligrams, they should be seeing a benefit. But just because they don't get benefit with 1 doesn't mean it's not going to work. Some folks need 6, 8, 10, 12. I've had folks, there's not really a max dosage, but what people kind of general practice, which is the other thing you want to go by, is you'd want to keep it, you want to keep it somewhere around 20 milligrams. But again, this is based on tolerance, the balance, like Dr. Fogel was talking about, balance the benefit with the side effects. And some folks, I've even given them, a good chunk at night, maybe 6 milligrams, 8 milligrams at bedtime, and then 2 milligrams in the morning for people who just have really intense, like breakthrough, re-experiencing symptoms. Can give it to them during the day. There's nothing wrong with that. So yeah, I think Zoloft, 25 for 3-4 days, and then up to 50, see them back in a month, and 1 or 2 or 3 milligrams of prazosin at night. I think that's a great start. Trazodone could be another option, again with the orthostasis concern there. But yeah, I think that's good. Reduce use, refer to therapy. Ask this guy, if you're in the private sector, if he's service connected and if he wants to be. Could try to help him get hooked up for benefits that he has earned through his service. But that's kind of it for this guy. Sometimes folks with traumatic brain injury, SSRIs are not as helpful for irritability. They may almost be kind of destabilizing. So sometimes folks with PTSD, especially if they have TBI history, will benefit from a mood stabilizer. Like this guy, he has a temper, but he doesn't describe himself as violent. Let's say he's not violent, but Depakote can be real helpful at bedtime for folks with a lot of irritable, kind of explosive, that sort of disinhibition that can come with a brain injury. So if you can calm the brain down a bit, and you'll see Depakote used a good bit. That's just another option. Plus, if they're not sleeping, that can help as well. So I think that's the last slide. Dr. Fogger, any closing thoughts?
Just generally, find somebody's got PTSD. Therapy is going to be really important to ensure that this person is willing to do that. How a person feels about therapy is real important. If they feel it'll be useful, it'll be useful. If they feel the medication is going to be more useful than the therapy, I would say go with what they're willing to do. Some folks aren't interested in therapy because they're afraid. And so you begin with wherever they are willing to go. Not everyone's going to respond to all medications, and different medications are fantastic for one person and work really well and don't work at all for another. So it's entirely individualistic in terms of treatment for PTSD. Nothing works 100%. And that would be my closing statement is that when you're working with people, be patient, keep reading, read studies about what works and what doesn't. I would caution you, though, that when you're reading studies, to look to see what their sample is, and if the sample they're using is not similar to the people that you're treating, then that information is not necessarily going to be as useful because it's particular to the group of people that they are looking at. So that would be my take home is if you're going to read studies about PTSD and you want to use that information in your practice, ensure that the people who are being studied match your clientele. So that would be my statement.
Mm-hmm. Yeah, lots of good information on va.gov as well. Any other last minute questions? We've kept y'all late, so we're going to wrap it up unless there's kind of any final comments or questions.
let's shut it down. And then next week we come back again with some additional information. We're going to talk more about military and PTSD on our next presentation next week.
Sounds good. All right, everybody. Y'all have a good evening.